Sanjay, how much time do we have for questions and discussion?
We have about 20 minutes.
20 minutes.
Okay, perfect. So Sundar, let me start with you, and Dr. Tuttle can come back. One of the things that you saw in the Emperor Preserve, of course, and
we have
full
20 minutes of panel discussion. We can have.
Yeah, I finished 1 minute early.
All of them.
Okay, Sundar. So let me start you on this, because it's fun to start you on this. So remember that letter that came for the Emperor Preserved study. But I was reading the Emperor Preserved, and something that's very interesting is that the heart failure benefit was seen only if the EGFR was less than 60. So what I mean, and Dr. Tuttle can please join in this, but is there something that's happening that you need somewhat of a worse disease in one organ to help with the other? So
okay, very good question. I had the slide, but for want of time, I took it out. Now we have to remember that it was 40% reduction. He transformed it and redid the data, Dr. Packer. He published that in the European Heart Journal. He made it 50%, and then he clearly showed, but this is all post hoc, that after 60, it doesn't work. The curves are beginning to go over there. I will defer that to Dr. Tuttle, but we have to remember that the people who were more than 60 apparently were women with more hypertension and more atrial fibrillation in the thing. So I defer to Dr. Tuttle, who has far more experience in why it would not happen.
Dr. Tuttle?
Yes, hello. Well, again, we really can only speculate at the observation, but those who have preserved ejection fractions and higher GFR are healthier people. And it may be that within the time frame of the study, there's just not enough opportunity to show a benefit on outcomes. And, I think that's one of the reasons, for example, in the other class of newer glucose-lowering agents, the GLP-1s, the cardiovascular outcome trials, it's easier to show an effect on albuminuria than GFR because they don't have very much kidney disease. And so by analogy, what I would say is that when you look at people with preserved ejection fraction and preserved GFR, they aren't as sick. And so within a short period of the trial, you're not going to be as able to demonstrate a benefit.
Except, if I may add, that we are looking at two different mechanisms of action with the GLP-1 RAs versus the SGLT2 inhibitors. In the SGLT2 inhibitors, you are seeing separation of curves in other things far too early. So how can the time argument, pardon my naivety, work with this?
Oh, well, what I'm talking about is not the time of the therapy, but the course of disease. If you're studying people who have preserved ejection fraction and normal GFR, it's going to take them a lot longer to have events. So in order to show any kind of treatment effect on the event, you have to have enough events to measure something. So I think people who are being studied earlier.
Yeah, I fully agree with Dr. Tuttle. The EGFR in the heart failure trials, the Emperor Preserved was about 60, 61, 66 ml per minute over there. Whereas in the Credence trial, it was 53, and in DAPA CKD, it was 43. Plus, those people were albuminuric, so the more protein, almost a gram. These people didn't have that much protein. So it's two different populations, and as she rightly said, EGFR slope is a thing, and that's what was the pushback from the nephrologists against Dr. Packer. He said, first of all, it is hypothesis generating that more than 60 doesn't work. But second of all, you need some more time. These are lower risk for the kidney. The heart, yes, they have heart failure. They have some kidney failure, obviously. They don't have that much proteinuria. And the EGFR is still reasonable.
And of course, that even with the heart, it's the 40 to 50s that really showed benefit analysis.
Right.
So I think, it's a very interesting trial because it's sort of nuanced out some of the other things that came from the DAPA, HF, and CKD. Dr. Makkar, you want to add?
Just coming back to the EGFR thing, we saw the benefit even in DECLARE, which had a population with absolutely normal, well-preserved kidney function. So what do you say about that?
In DECLARE, it was mostly an effect on albuminuria, not on kidney endpoints. And you can detect that earlier in the course of disease. And so that's why for the cardiovascular outcome trials, people were selected for cardiovascular risk. And by design, they excluded people with more advanced CKD. So the effect is primarily on markers of early disease. But if you go further along the disease trajectory, like Dr. Mundalar said correctly, in Credence and DAPA CKD, they had more advanced kidney disease. So still there was an effect on albuminuria, but they started having events. So then you could measure an effect of the treatment on the events.
Yeah, if I may add, please. Dr. Mucker, in DECLARE TIMI, it was a composite renal outcome which included
Yeah.
albuminuria.
But
That
there
is
was a benefit in terms of heart failure reduction also.
correct. Correct.
So that was interesting part. So we have a question from Professor Das. Do you see any differences between EMPA being, better than others, or, it's more like a class effect?
Is it for me or Dr. Tuttle?
Anyone
can
can
answer.
actually both. We can have viewpoint of both.
Yeah, in my opinion, it's a class effect.
I totally agree.
Despite vertex CV.
But the renal one, see, there's people have argued long and strong about tugliflozin. There were 2 doses. There was 100. There was a 300.
Right.
There were problems with the dosing. If we are talking of a class effect, we're talking of a class effect, including the SGLT1/2 blocker, sotagliflozin.
Yeah.
So can I have both of you talk about this? Let's say a patient who's diabetic is now A2G2, has some amount of urine albumin creatinine ratio of around, about 300, and the EGFR is 60. What would be your hierarchy of drugs with all the data that we have? What comes first, what's second, and what's third?
That's a really great question, because if you look at the guidelines, the hierarchy has really been more dependent on when they received regulatory approval than really on the biological mechanisms or the effect size. So if we go strictly by the guidelines, we'd start with an ACE or an ARB and then add an SGLT2. But this may be a little controversial, but I'm going to go ahead and say this. If you look at the cardiovascular outcome trials, where about 20% of the patients were not on an ACE or an ARB, and irrespective of albuminuria, still demonstrate an effect on kidney endpoints, and not just on new onset macroalbuminuria, even substantial GFR decline or kidney failure. And then if you look at the effect size in the kidney trials, with hazards ratios of 35 to 40% on top of an ACE or an ARB, these are the biggest risk reductions we've ever seen for any therapeutic in kidney disease. And as Dr. Mundalar correctly pointed out, both Credence and DAPA CKD were stopped early for overwhelming efficacy. It's never happened in the field before. It hardly happens in any field of medicine. It's a high bar to stop for efficacy. We stop trials for safety or futility more easily. And then the other thing, too, that I also agree with him about is, even though it was a secondary endpoint, a 31% reduction in all-cause mortality from any condition with any treatment is remarkable. And so, to be honest with you, I wonder if we just started from a clean slate and we looked at the risk reductions, whether or not we would start with an SGLT2.
So, Sundar, you just mentioned about sotagliflozin. So, coming to the data from SCORED, this did not involve patients based on albuminuria as a criteria. And though, the renal endpoints were not analyzed for superiority, but there was a strong indication for renal benefit. What is your take on that?
As I said, if it's a class effect, it's a class effect for that. Now, the people in the the worsening heart failure, they were a little different population. Also, we have to take into account the studies were terminated early because of lack of funding. So They barely got,
Right.
I don't know what percent of the original people. And, they talked to the regulatory people, put it together. And second, now for what it's worth, the endpoints were not adjudicated because it costs money to adjudicate events. Now they presented data that adjudication really doesn't add much. It's what the investigator thinks. But we think a lot of things and we just say, hey, that is what it is. They did not adjudicate it. But there were multiple things. But let me point one thing out. People seem to think that an SGLT1 and 2 inhibitor blocks both SGLT2 and SGLT1 in the kidney. You cannot block the SGLT1. Then you will not live because all your glucose is going to get out. That's not possible. That SGLT1 effect is in the gut, where you get some more lowering and you get more diarrhea, which was seen with the thing over there. So how much SGLT1 adds to SGLT2 with that, I don't know. I don't believe I don't believe it is too much, in my opinion.
But the plus point seen with the dual SGLT1, SGLT2 was that they were still efficacious in glucose lowering, even at lower levels of GFR.
Yes.
So that was one big plus point.
Probably due to the GI effect rather than
whatever.
Yeah.
Sundar, I want you to take your view on the previous question, which I asked Dr. Tuttle. So an A2 G2 EGFR, and the patient needs also glucose lowering. What will you do? What will you should we do? So the question is, a patient who comes to my clinic who's not who we have some, normally we would add an ARB and an SGLT2, but should you also add a MRA now and with the Fidaro?
The thing, what we have to remember, and Dr. Tuttle rightly pointed out, it is just when the studies were done. These came earlier. And now the ADA calls it a living guideline. Means anytime something happens, before they used to wait 1 year out before you did anything. So they're updating it. As of today, the diabetes guidelines says if you have atherosclerotic CVD, then go for a GLP-1. If you have heart failure or kidney failure, go for an SGLT2. If they cannot tolerate it, contraindicated, then go to a GLP-1. The only reason being is the studies have to come out with the dedicated. That's the only reason you will get an indication, and the payers, the insurance companies, will pay for it. In the US, everything is driven by payment. Who's going to pay for it? Absolutely. Personally, for me, if price is not an equation, I use it a lot. I use the combination of GLP-1 and SGLT2. In fact, Mike Nock and Juris Meyer wrote a beautiful editorial in Lancet. They said SGLT2 inhibitors and GLP-1, a marriage made in heaven. But cost is an issue. And we have to study it together. We have not, and like you said, you put finerenone in the mix. Too little data to see what happens. And then the cardiologists have taken a bold step. If you read it, they said these are the 4, you got to be on it and you got to get there within a month to 2 months, because after this sotagliflozin and the other studies, they said you wait 1 month, the people are already dead. The events have already occurred.
Right. So it also depends on the risk, isn't it? So can I have both your views on this? In terms of, we constantly are talking about RR, right? Relative risk reduction. But in terms of absolute risk reduction, what is going to happen? For one, let's take 2 different EGFRs, one at 60 and another at 30, right? So do you think that at 60 you could say that okay, let me just use one agent, but at 30 throw in the towel? throw in the whole library on.
I think that's a really good question, and that's why I sort of alluded to it a little bit about more precise phenotyping of patients. And I agree with you, because particularly when GFR drops below 30, GLP-1s are very effective still at glucose lowering. So you can use that indication if you want. They have cardioprotection, but we have some very strong evidence that even in advanced CKD in Award 7, that there was a reduced risk of GFR decline in true kidney disease endpoints. And I didn't show you the data, but we had enough events, because even in that trial of 600 patients, we had 60 events in 1 year because they were very high risk. And more than half were kidney failure going on dialysis or transplantation. So indisputable endpoints, and they were comparably reduced. It wasn't just a GFR endpoint. So I do think we need to consider agents at more advanced CKD. And with regard to finerenone, I see George just jumped on. But in the Fidelio trial, people who were drop-in SGLT2 inhibitor users still had comparable benefits. So, you know, we are moving into an era of combination therapy. I think we're still learning how to use them, but especially somebody at high risk of heart failure, that's another person where I would consider using finerenone together with an SGLT2.
Just a follow-up question, because, you know, both the MRA and the ARVs are prone to cause hyperkalemia, especially at lower EGFRs. If you would have to drop one, what would you do?
Well, you know what? An SGLT2 inhibitor actually helps control hyperkalemia. In fact, they just published a post hoc from the Credence. And really, again, I loved Dr. Mudaliar's presentation of physiology. This is why it's so important to understand mechanisms to help us apply therapy. So anytime you increase urine flow and distal delivery of solutes, including sodium and potassium, there's increased potassium secretion in the distal nephron. So actually applying an SGLT2 to an MRA can mitigate hyperkalemia, and again, combination therapies not only for efficacy, but for safety so that we can apply agents that we might otherwise not be able to use.
So, you know, yeah, Anjali, you want to say something?
Taking that point forward, we have, clinically speaking, we have a lot of patients who are ESRD and on hemodialysis who need to really reduce the hospitalization for either heart failure, oblique, or fluid overload. Do you see a point of using such drugs to reduce the hospitalization due to fluid overload? I know right now we don't use them, but do you see a potential over there? Because that's a tough thing to manage.
So that's a really good question, especially again with the physiology that Dr. Medaliar presented. There is rationale for using SGLTs even in dialysis patients, especially from a heart failure and cardiovascular perspective. And there are groups right now, I'm involved in 2 of them, trying to get trials going in kidney transplant and type 1 diabetes in particular. But one of the challenges is that we will have to have governmental funding because pharma isn't going to cover those. And that's been our biggest challenge so far in the US, working with the NIH to try to organize some trials. But let me turn it over to Professor Medaliar and see what he thinks.
So this is last question. This is last question. Yes, Sundar.
No, I fully agree with Dr. Tuttle said.
Okay, so the closing question is, you know, we have discussed in detail the nitty-gritty of SGLT2 inhibitors and trials, and with the, you know, GLP-1, RAs and everything.
So
large major, yeah, we are closing. Last question.
No. So we have a question from Dr. C.S. Yagnik in the chat box. I think
it's a comment. It's a comment.
It's just a comment. So
it's a comment. So what is the large amount of people here? Most of the people logged in here are clinicians, and they need to understand where you position these molecules. We have discussed in patients with the, you know, kidney disease and heart failure. For a typical garden variety type 2 diabetes patients, what is your take on using these molecules and where you position them?
So the question is, in a patient's, I mean, I used to be on the ADA's you know, professional practice committee, which did it. So I follow the ADA guidelines. I still use metformin first line, but now at least they've moved up to say if there is any, you know, the CKD or any which way you define it, most of our patients usually are getting with metformin and an SGLT2 inhibitor up front. And to Krishna Sheshadri's point is, will I wait from 60 to 30? This is a lifetime burden. You don't want the disease to go down and then say, okay, I'm going to do it. It's far harder to stop it when you're down the slope than to prevent it. Do we have any evidence? No, but it kind of makes physiologic sense. You know, with the PCSK9, it's classic. It's a lifetime burden of that extra LDL sitting in your thing over there. So that is just my opinion. I have lots of patients on SGLT2, GLP-1, insulin. Let's not forget insulin. If you want good glycemic control, you need insulin, which is by far.
I think,
Sure, sir. I think it was a wonderful session and very thought-provoking, very clear, practically useful. So with that, I would like to thank Dr. Catherine Tuttle as well as Dr. Sundar Mudliar, as well as Dr. Brish Makkar and Dr. Krishna Sheshadri for having this wonderful